Hello, this is Dr. Madhurima Ganguly, your pediatrics faculty at Global Academy of Medical Sciences, and we are doing a pediatric marathon series comprising each and every subtopic of pediatrics. The main motive of this pediatric marathon series is to have a very brief overview of the entire subject in a very short time. We have already completed pediatric rheumatology in the series 1 and we have also done pediatric cardiology. The next we are going to do is the pediatric endocrinology and pediatric pulmonology. Okay, so this marathon is going to help you in all the upcoming exams. So this is a must watch for the Fmge students who are going to sit for the July 2023 session, and also for the upcoming INICET and the NEET or the next. So let us start with the pediatric endocrinology. The first thing we are going to read is about the short stature. So what is the most common cause of short stature? The most common cause of short stature is physiological. And the most common cause of physiological short stature is constitutional delay in growth and puberty. And the most common cause of pathological short stature is protein energy malnutrition. And the most common cause of hormonal short stature is hypothyroidism. If hypothyroidism is not given in the option, the next best choice for this is growth hormone deficiency. So in growth hormone deficiency, usually we need to assess the growth hormone levels. Sometimes we go for the provocative tests also, and in case of growth hormone insensitivity, we go for IGF-1 levels. Okay, because many a times the problem is not with the growth hormone, the problem is with the IGF-1 levels. Most common cause of genetic disproportionate short stature. I have already discussed about this MCQ in pediatric rheumatology session. The answer to this is achondroplasia. Okay, so most common cause of short stature is physiological. Among physiological short stature, we have constitutional delay in growth and puberty. In pathological short stature, we have PEN. Hormonal short stature, we have hypothyroidism followed by growth hormone deficiency. And most common cause of genetic disproportionate short stature is achondroplasia. So actually, whenever a child comes to me with short stature, first you need to see that whether it is a physiological short stature or a pathological short stature. So usually in the physiological short stature, the growth velocity is maintained, and if the growth velocity is not maintained, then it is pathological short stature. In physiological short stature, which is again the most common type of short stature, we have two categories. One is the constitutional delay in growth and puberty, which is by far the most common cause of short stature overall, and it is more common in boys. So more common in boys. Constitutional delay in growth and puberty, more common in boys. And remember this constitutional delay in growth and puberty, bone age is delayed. Bone age is delayed. And the next is familial short stature. That is, the short stature runs in the family. Now what happens is that the ultimate height is less in familial short stature, but what happens in constitutional delay in growth and puberty, usually there is a lesser height, but once the child attains puberty, they can attain the target height, but that is not so in familial short stature. So we have a not a good prognosis in case of familial short stature, because the short stature runs in the family. The mother is short, the father is short, and the child is also short. But in constitutional delay in growth and puberty, only the bone age is delayed, which is compensated after the child attains puberty. So the height age is better in constitutional delay in growth and puberty as compared to familial short stature. Now coming to the pathological short stature, already I told you the most common cause is protein energy malnutrition. Usually here we assess that whether it is a proportional short stature or it is a disproportionate short stature. To understand whether it is a proportionate short stature or disproportionate short stature, usually we do the upper segment lower segment ratio. Now as we know that upper segment lower segment ratio, at birth it's 1.7:1 and at 3 years it's 1.3:1, and near about at 8 to 10 years it comes to around 1:1, right? So upper segment lower segment ratio, if it is proportional, we call it proportional short stature. If it is not proportional, that is either the upper segment is more as compared to the lower segment or lower segment is more as compared to the upper segment, we call it as disproportionate pathological short stature. And most common cause of genetic disproportionate short stature, as I was telling, is achondroplasia, right? Now I also told you about this, that in some cases like mucopolysaccharidosis, hemivertebra, port spine, all these cases the lower segment is more as compared to the upper segment. But what happens in achondroplasia? In achondroplasia, upper segment is more than the lower segment. Okay, so already this is a discussed MCQ, that is achondroplasia, autosomal dominant condition, which is the most common non-lethal skeletal dysplasia. Here it is the most common cause of genetic cause of disproportionate short stature. And another things, in short stature we do a battery of investigations, but in order to know the bone age we do a wrist x-ray. Okay, the x-ray of the wrist joint, and this x-ray of the wrist joint is usually done to see the ossification of the PC form. So you do the, for assessment of bone age we do the x-ray of the wrist joint of the non-dominant hand. In neonates we do an x-ray of the knee joint. However, in children, to assess the bone age, we do x-ray of wrist joint of the non-dominant hand, Okay, now see this diagram. So can you appreciate the coarse faces and the puffiness of the face in this child? And also the child appears a bit carotinic, orangish discoloration, and there is umbilical hernia with abdominal distension. So there is umbilical hernia with abdominal distension along with puffiness of the face and a bit of coarse faces. So this is nothing but congenital hypothyroidism. And in congenital hypothyroidism, we know that there is going to be prolongation of the physiological jaundice. That is a very important clue in congenital hypothyroidism. Along with that, there can be bradycardia, and also we are going to get umbilical hernia and this coarse faces. Okay, so let's understand a few one-liners from congenital hypothyroidism. And why are we very much concerned about this congenital hypothyroidism? Because it is the most common cause of preventable mental retardation in case of children. Okay, so the first question is, what is the most common cause of congenital hypothyroidism? So overall, what is the most common cause of congenital hypothyroidism? The overall most common cause, so congenital hypothyroidism, overall most common cause of congenital hypothyroidism. So most common cause of congenital hypothyroidism overall is thyroid dysgenesis. So first of all, you what happens in congenital hypothyroidism, you need to do 2 or 3 things. Like first, you need to understand from the clinical features that we are dealing with congenital hypothyroidism. Next, we need to find out the cause. So for first of all, clinically you suspect that you are dealing with congenital hypothyroidism. Then you go for the thyroid profile, that is the TSH FT4, and there you find that the TSH FT4 is suggestive of congenital hypothyroidism, right? That is the T3 T4 is low and the TSH is more. That is the most common laboratory or biochemical finding in case of congenital hypothyroidism. However, if there is a pituitary cause, the TSH is also going to be low, right? So most common cause is thyroid dysgenesis. If it is a most common cause of thyroid congenital hypothyroidism with palpable goiter, remember, if you are asked most common cause of congenital hypothyroidism, the answer will be thyroid dysgenesis. But if it is the most common cause of congenital hypothyroidism with palpable goiter, then the answer is going to change. The answer will be thyroid dysharmonogenesis. Thyroid dysharmonogenesis. So, and in this thyroid dysharmonogenesis, the most important is the organification defect. Okay, so the most common cause of thyroid dysharmonogenesis is most common cause with palpable goiter, thyroid dysharmonogenesis. The problem is with the organification defect. Now there are few diseases where we really do the newborn screening, and newborn screening is very important. Like newborn screening is important for cystic fibrosis, newborn screening is important for phenylketonuria, other inborn error of metabolism, and newborn screening is also important for congenital hypothyroidism, because as I was telling, it is a preventable cause of mental retardation and the lead time is 2 weeks. So if we can diagnose congenital hypothyroidism, then we can prevent mental retardation, and that is very important. So once the signs come in, like you get a prolongation of physiological jaundice, there is abdominal distension, coarse facies, bradycardia and all, when the child becomes symptomatic, usually even if you give levothyroxine supplementation, you're not going to reverse it. So the lead time is 2 weeks and the prevalence is very high, 1 in 1500 in India to 1 in 4000 in the Western world. So we need to prevent this, and that is why we need to do a mass screening in our SNCU and the NICU. So if you are asked most common cause of mental retardation in children, the answer will be Down syndrome. But if the question is most common preventable cause of mental retardation in children, the answer is going to be congenital hypothyroidism. So that is why we stress on screening. When do we screen and how do we screen? So the screening is done on day 2 to day 3 of life. So the best answer over here is day 3 of life, not the day 2. Okay, and remember, we do not do it in the initial 2 days. We always do it after 48 hours because there can be a maternal surge of anti-TSH antibodies. And what is the method that we follow? The method is Hill-Pat prick test. What should be assessed? We should do, ideally, if we have a good infrastructure and if it is cost, there is no problem with the cost, we do a complete profile with TSH and FT4. But otherwise, the normal thing that we usually do is that we do a TSH, and if the TSH comes to be abnormal, then we go for FT4. So if the TSH is more than 20, then we need to do the FT4. So it's a TSH primarily with a backup of T4. And what drug do we give? We give levothyroxine, 10 to 15 microgram per kg per dose. Okay. So most common cause of congenital hypothyroidism, thyroid dysgenesis. But if you're having a palpable goiter in the question, or if you have an image based question where you have this palpable goiter, the answer will be thyroid dysharmonogenesis. When do we screen? How do we screen? And it is preventable, and what is the drug we use? Now I would like to do another condition that is associated with hypothyroidism and sensory neural hearing loss, that is known as the Pendred syndrome. Okay. So Pendred syndrome is basically because of PDS gene defect, and it presents with sensory neural hearing loss plus congenital hypothyroidism. Another question, it is not related to congenital hypothyroidism but autoimmune hypothyroidism. What is the most common autoimmune disorder in type 1 diabetes mellitus in children? Whenever we get a child with type 1 diabetes mellitus, we need to screen for thyroid, because there is a chance of autoimmune thyroid disease, which is the most common associated autoimmune disease in type 1 diabetes mellitus. So that finishes our one-liners from hypothyroidism and the thyroid disorders. And another question you remember that in most common cause of the hyperthyroidism in children is Graves' disease. So most common cause of hyperthyroidism in children is Graves' disease. Okay, next one-liners we are going to do it for congenital adrenal hyperplasia. Okay, so congenital adrenal hyperplasia. So first is the Mendelian inheritance of congenital adrenal hyperplasia. It is autosomal recessive. So what is the drug that we give in salt wasting type? So we know that there is cortisol deficiency, there can be mineralocorticoid deficiency. Salt wasting means there is deficiency of mineralocorticoids and the child may have ambiguous genitalia. So we need to approach all these three things. So for cortisol deficiency, we need to supplement with cortisol. So what is the cortisol we supplement? We supplement with hydrocortisone. If there is salt wasting, that is mineralocorticoid deficiency, we need to supplement with mineralocorticoid. We give fludrocortisone. And if you are having ambiguous genitalia, next we need to go for a cosmetic surgery that is known as the vaginoplasty with clitoral recession. So vaginoplasty plus clitoral recession. So what is the drug to prevent in vitro virilization? So again, the first question was, if the child is having congenital adrenal hyperplasia, what drug I am giving? That is hydrocortisone. But the next question is not regarding that the child is having congenital adrenal hyperplasia. It is about a drug that is for prophylaxis of CAH. That is nothing but dexamethasone, and it's a very, very important question. I am repeating this for the third time, I think. That is dexamethasone as a fetal therapy. We are using it for antenatal steroids. We are using it for maternal ACLE for prophylaxis of congenital heart blocks, and the third is for preventing in vitro virilization in congenital adrenal hyperplasia. So first question is what drug you give? The answer is dexamethasone. Why do you give? To prevent in vitro virilization. When do you give? As soon as possible, or rather you should say that as soon as pregnancy is confirmed. The third question is how long do you give? So usually in the second trimester we go for a CVS, that is chorionic villus sampling, and in the chorionic villus sampling we determine the karyotype, and if it is a male, okay, so if it is a male we stop the drug, but if it is a female we continue the drug till pregnancy. Understood? What is the most common type or most common enzyme deficiency in congenital adrenal hyperplasia? The answer will be 21 hydroxylase deficiency. And remember, 21 hydroxylase deficiency falls in the category of salt wasting type or salt losing variety. What is the most common type of congenital adrenal hyperplasia associated with hypertension? Another way of putting it, putting the same question, most common cause of congenital adrenal hyperplasia with hypertension, or most common cause of hormonal cause of hypertension in infancy, or most common endocrine cause of hypertension. And the answer to this question is 11 beta hydroxylase deficiency. So 11 beta hydroxylase deficiency will present with salt retaining variety. So salt wasting means we are losing salt, and what do we mean by salt? Salt, by salt we mean sodium, right? So we are going to get hyponatremia. So if there is hyponatremia, there is going to be hypovolemia. The clinical finding is going to be that of shock. There is hyperkalemia, metabolic alkalosis. Because of cortisol deficiency, we are going to get hypoglycemia. And what happens? There is cortisol deficiency, there is increased ACTH, and there is increased formation of POMC, that is an intermediate, which results in hyperpigmentation. So clitoral hyperpigmentation. So have you understood the feedback thing? That is, there is a cortisol deficiency, there is a mineralocorticoid deficiency, which is giving a negative feedback loop, which is not possible. That is why there is increased secretion of ACTH. Because of increased ACTH, there is increased POMC, and because of increased POMC, we are going to have hyperpigmentation. Next is the salt retaining variety. So in salt retaining variety, as the name suggests, there is retaining of salt. So we'll have hypernatremia. So if there is a hypernatremia, there is increased blood volume that will present with hypertension. So if there is a hypertension, we are going to have hypokalemia. And again, if there is a cortisol deficiency, we are going to get hypoglycemia and hyperpigmentation as the common findings. Right? So if you are asked as a clinical based question, that is a child presented to us with hyponatremia, hyperkalemia, shock, along with ambiguous genitalia, what is the clinical diagnosis? The diagnosis will be 21-hydroxylase deficiency. What drug you are going to give? Hydrocortisone, fludrocortisone, and surgical correction for ambiguous genitalia. What is the drug that could have been given to prevent such condition? The answer is dexamethasone. Another way of putting the same question, a neonate presented with shock along and ambiguous genitalia with clitoral hyperpigmentation and hypoglycemia, and a venous blood gas is drawn, which suggests hyponatremia. What other electrolyte abnormality is possible in this child? The answer will be hyperkalemia. Okay, so that finishes our one-liners from congenital adrenal hyperplasia. Next is a very important electrolyte that we are going to talk, that is the potassium, right? So potassium is one of the very important electrolyte. So what is the first sign of hyperkalemia in ECG? So the first sign of hyperkalemia in ECG is tall picked T wave. So that is known as hyperacute T wave. In the later phase of hyperkalemia, you find the sine wave pattern. So sine wave, the word sine came from sine and cos theta that we read in mathematics. So that is the sine waves like this. This sine waves you get when the potassium value crosses 8. Right? So another question from hyperkalemia is that how do you manage hyperkalemia, which is very important. Suppose the patient is on some drugs, and you do an ECG, you find a hyperacute T wave, and what drug you will give next? The answer will be calcium gluconate. Now what is the mechanism of action of calcium gluconate? It stabilizes the cardiac membrane. C for C. Calcium gluconate stabilizes the cardiac membrane. It has no role in reduction of potassium level. If you want to reduce potassium level, you need to give diuretics, that is the loop diuretics, furosemide, or you need to put the child on salbutamol nebulization, because you know what happens, the side effect of salbutamol is hypokalemia. So we utilize the side effect of salbutamol. So salbutamol nebulization and insulin dextrose. So salbutamol nebulization, insulin dextrose, furosemide, all these can reduce blood potassium levels either by directly reducing the potassium levels or by enhancing the excretion of potassium. However, calcium gluconate do not reduce potassium levels, it only stabilizes the cardiac membrane, because if you are having hyperkalemia, it predisposes the child to dangerous arrhythmias. So we first need to stabilize the cardiac membrane. For stabilization of the cardiac membrane, we give calcium gluconate, and sine waves are found when the potassium value, serum potassium value, is more than 8. U waves are found in hypokalemia. So prominent U waves are found in hypokalemia. So we need to do two syndromes associated with potassium. One is the refeeding syndrome and the other is the tumor lysis syndrome. So first we are going to do is the refeeding syndrome. You know, in a child with prolonged starvation or a child with NEC who was on NPM for a large number of days, or a child with SAM, severe acute malnutrition. So when you start feeding in this category of patients, what happens? There is increased surge of insulin and there results in a condition which is known as refeeding syndrome. What comes? You will be given a scenario. There is a child with severe acute malnutrition develops the following electrolyte abnormalities. So what electrolyte abnormalities? We can have hypophosphatemia, we can have hypokalemia, hypomagnesemia. So that there is going to be decreased magnesium, decreased calcium as well. So all this is basically because of refeeding syndrome, because we find that the electrolytes go to the intracellular compartment from the extracellular compartment. That occurs in refeeding syndrome, mainly in SAM or in prolonged starvation, when the child starts eating. And the next one is very, very important, that is about the TLS or the tumor lysis syndrome. So let's break the words. Tumor lysis syndrome, it is a syndrome which occurs because of the lysis of tumor. So it can occur either before chemotherapy or usually 12 to 48 hours after the start of chemotherapy. Okay, and in high grade tumors. So what high grade tumors we are talking about? It can be either non-Hodgkin lymphoma or ALL or AML. In non-Hodgkin lymphoma, usually I am talking about Burkitt's. Burkitt's, you know, it is the translocation 814 or lymphoblastic lymphoma. In ALL, if the total leukocyte count is more than 1 lakh, and in AML if the total leukocyte count is more than 50,000. Okay, so we can have tumor lysis syndrome, and because of the lysis of the tumor we have got various clinical manifestations. So what will that be? We can have hyperuricemia, that is the uric acid level will increase. Next we are going to have hyperkalemia, hyperphosphatemia, and hypocalcemia. Okay, so uric acid levels are going to be more, it's more than 8. Hyperkalemia, potassium levels more than 6. Phosphatemia, hyperphosphatemia almost more than 2 millimoles, and hypocalcemia less than 1.7 millimoles. So this is the presentation. So many a times this comes in question. In tumor lysis syndrome all are possible except usually in the option they give hypercalcemia, that is going to be the wrong answer. We have hypocalcemia. So whenever in a patient you are having hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, it usually predisposes to metabolic acidosis and acute renal failure. So there is the development of AKI in a child. So how can you manage such condition? So for hyperuricemia, you need to give rasburicase. If rasburicase is not available, you can give allopurinol. So for hyperkalemia management, already I told you need to start on calcium gluconate for stabilization of the cardiac membrane, and then for reduction of serum potassium values you need to give furosemide or insulin dextrose, or even you can give salbutamol nebulization, and if it is refractory then we have to go for dialysis. And for hyperphosphatemia we can give phosphate binders like sevelamer, etc. And remember, we do not give calcium, extra calcium to the child, because there is renal failure, right? There can be precipitation of nephrocalcinosis and it can result in further exacerbation, and we maintain adequate hydration. By Holiday-Saker method only we calculate the fluid, and we give extra 2 to 4 times the maintenance fluid we give to the child. and we monitor the urine output. So the monitoring of the vitals, monitoring of the urine output, monitoring of uric acid, monitoring of phosphate, and daily monitoring of potassium, calcium is very, very important in account of the tumor lysis syndrome. You must be reading tumor lysis syndrome in your pathology class as well. It's given very nicely in Robin's textbook of pathology. At least you need to remember what happens to what electrolytes. Uric acid more, potassium more, phosphate more, calcium low. Found in high grade tumors, it can be before chemotherapy and after chemotherapy. More common after initiation of chemotherapy. How long after chemotherapy? 12 to 48 hours after chemotherapy. What are the treatment options? Hydration, urinary alkalinization, okay, and we have to go for rasburicase, allopurinol, management of hyperkalemia, and usually we avoid giving excess calcium, and we need to go for phosphate binders. Now last is a very extra edge concept you may not remember, that is the transtubular potassium gradient. So transtubular potassium gradient, usually we calculate it with some values of potassium in urine and values of potassium in serum. So usually we find, in order to find out a cause of hyperkalemia or hypokalemia, we go for transtubular potassium gradient. So whether the cause of hypokalemia is renal or non-renal. Also in hyperkalemia, whether something is related to aldosterone or not, we do it. In hyperkalemia, you just remember this value. If it is more than 10, then we call it as hyperkalemia. But what happens, suppose in a hyperkalemia patient, we usually expect the transtubular potassium gradient to be more than 10. Right? So suppose in an hyperkalemia patient, if we find that the transtubular potassium gradient to be less than 7, then it is spurious. So in a hyperkalemia patient, if the TTKG is less than 7, it is spurious. So it is of two, we can have two diagnoses. If the TTKG less than 7, but the serum potassium is more. So serum potassium is around 6.5 or 7, but the TTKG is less than 7. So there are two options possible. Either there is aldosterone deficiency or there can be aldosterone resistance. So we can find out the cause just by giving supplementation of aldosterone. Okay, so you give aldosterone to the child, and if after giving aldosterone to the child, TTKG increases to more than 7, then it is aldosterone deficiency. But if it does not increase, then it is aldosterone resistance, right? So here in the potassium, I would like you to remember about the ECG changes in potassium. Very important question. Mainly the first sign, okay, the sine waves, the U waves, the refeeding syndrome, tumor lysis syndrome, and a very short note on transtubular potassium gradient. Okay, so we did congenital hypothyroidism. We also did about the congenital adrenal hyperplasia, and thirdly we also did about the potassium. Now let me tell you, type 1 diabetes mellitus predisposes to diabetic ketoacidosis in children, and you need to remember in diabetic ketoacidosis, mostly because of type 1 diabetes mellitus, and I already told you autoimmune thyroid disease is the most common autoimmune disorder associated with type 1 diabetes mellitus. Now remember as a dictum, in any child presenting to you with type 2 diabetes mellitus, आपको क्वेश्चन में पूछ रहा है कि कब आई स्क्रीनिंग करना है. व्हेन डू वी डू आई स्क्रीनिंग इन टाइप 2 डायबिटिस मेलाइटस, व्हेन डू वी डू स्क्रीनिंग फॉर माइक्रोस्कोपिक हेमाचूरिया इन टाइप 2 डायबिटिस मेलाइटस. all this questions, the answer will be as soon as possible. So in type 2 diabetes mellitus, if you are asked about any question related to screening of ophthalmological screening or microscopic hematuria screening, microscopic albuminuria screening, the answer to all these questions will be as soon as possible. However, in type 1 diabetes mellitus, you will say 5 years after the diagnosis of type 1 diabetes mellitus. So type 1 may we do it after 5 years. In type 2 may we do it as soon as possible. Only exception is celiac disease. So type 1 diabetes mellitus, if you have to screen for celiac in type 1 diabetes mellitus, usually we do it after 2 years and not after 5 years. So in all the cases, it is after 5 years after diagnosis in type 1 diabetes mellitus, celiac disease after 2 years, and type 2 diabetes mellitus as soon as possible. Another question, which viral infection is associated with type 1 diabetes mellitus? The answer is rubella. So rubella is associated with type 1 diabetes mellitus. Okay, and I'll be taking a separate class on DKA. because it is another very, very important topic. So that finishes my pediatric endocrinology, and now we are going to start with the pediatric pulmonology. So for starting of the pediatric pulmonology, we are going to do one of the very, very important topics, that is cystic fibrosis. Now in cystic fibrosis, we need to know how do we diagnose cystic fibrosis. So the criteria of diagnosis of cystic fibrosis is two. One is the clinical criteria and number two is the laboratory criteria. And for diagnosis, remember, we need both the criteria, clinical criteria plus laboratory criteria. So both clinical criteria as well as laboratory criteria is needed for the diagnosis of cystic fibrosis. Okay, so first let us see the clinical criteria. So what is the clinical criteria suggestive of? Clinical features suggestive of cystic fibrosis. So in case of neonates, we are going to have meconium ileus, meconium plug syndrome, or delayed passage of meconium. All this can be suggestive of cystic fibrosis in neonates. After that, there can be recurrent sinopulmonary infections. Bronchiectasis can be there in the child, right? And in the later on, what is possible, you can also get exocrine pancreatic insufficiency. There can be steatoria. And we can also have absence of vas difference. There was once a question in INICET 2022. There was one question on absence of vas difference is found in cystic fibrosis. This was a direct one-liner question which was asked. So clinical features which are consistent with cystic fibrosis or history of cystic fibrosis in sibling. Now that keeps me asking one very important question. What is the Mendelian inheritance in cystic fibrosis? So cystic fibrosis is autosomal recessive, right? So cystic fibrosis is autosomal recessive. Next, a positive newborn screening test for cystic fibrosis. So what is the newborn screening test that you do for cystic fibrosis? I already did one screening test, that is screening test for congenital hypothyroidism. Now next is the second screening test for cystic fibrosis. What is the positive newborn screening test? That is immunoreactive trypsinogen assay plus limited DNA testing. So we do a dried blood spot for immunoreactive trypsinogen assay ITA plus limited DNA testing. So these are the three clinical features. One is the clinical feature suggestive, or there is a positive family history in sibling, or there is a positive newborn screening test for cystic fibrosis. Next we come to the laboratory evidence of CFTR mutation. So what gene is involved in cystic fibrosis? The answer is CFTR. And CFTR minded involves the chloride channel. Okay. So two positive sweat chloride tests on 2 different days. Very important. So sweat chloride test is the screening test of choice in post-neonatal period. So if you're asked about the neonatal period, the answer will be ITA, whereas in the post-neonatal period, the answer will be sweat chloride test. So 2 positive sweat chloride tests on 2 different days. So 2 positive and 2 different days. So if you're doing a test on Wednesday and that comes out to be positive, you repeat the test after 2 weeks and that also comes out to be a positive. So 2 positive days on 2 different days, you get the sweat chloride test positive. Positive sweat chloride test is more than 60. Okay, that gives you a positive sweat chloride test. So you know that it is a laboratory evidence of CFTR mutation, or 2 CFTR gene mutations, not one. You need to have 2 CFTR gene mutations, or abnormal nasal potential difference measurement, or abnormal nasal potential difference measurement. Again, 3 clinical, 3 laboratory. Sweat chloride test being positive, CFTR gene mutation being positive, or abnormal nasal potential difference measurement. So this gives you a diagnosis of cystic fibrosis. Okay. Now next we are going to read some one-liners related to cystic fibrosis. What is the gene involved in cystic fibrosis? It's CFTR chromosome 7q. Can you tell me one congenital heart disease where chromosome 7 is involved? The answer is Williams syndrome, which presents with hypercalcemia, cocktail personality, hypertension, Elfin facies with supravalvular aortic stenosis. Right? So, and what channel is involved? Chloride channel. So, what is the drug that acts as a potentiator in case of cystic fibrosis? Or we have now numerous drugs that we can give for cystic fibrosis, but at least you should remember this drug, that is the ivacaftor. Next, most common type of cystic fibrosis involves the deletion of phenylalanine at 508 position. So phenylalanine 508 deletion is the most common type of cystic fibrosis. So already I told you what is the newborn screening test. It is the dried blood spot for immunoreactive trypsinogen assay plus limited DNA testing. What is the post newborn screening test? We have the sweat chloride test, and the value of sweat chloride test should be more than 60. And we need to know one syndromic condition that is known as the Carter-Jenner syndrome. So Carter-Jenner syndrome is associated with situs inversus plus bronchiectasis plus primary ciliary dyskinesia So situs inversus, bronchiectasis plus primary ciliary dyskinesia, this triad you are going to get in Carter-Jenner syndrome. Okay. Next, we are going to read this two important X-ray images. First, look at this lateral X-ray. So, lateral X-ray, look at the black pointed arrow. So, this is shaped like a thumb. Okay, so this is known as the thumbprint sign. So, thumbprint sign in lateral X-ray neck is suggestive of acute epiglottitis. Remember, acute epiglottitis is a bacterial condition. So, it is caused by Streptococcus pneumoniae, H. influenzae type B, etc. So, it's a bacterial condition. And if it is a bacterial condition, then the child is going to be toxic. That means there is going to be high-grade fever, stridor will be there, drooling of saliva, dysarthria is going to be there, and there can be airway obstruction also. So if the child presents to you with all these features, you may need to secure the airway, like you may need to intubate the baby to relieve airway obstruction. And if there is no airway obstruction, then you need to start specific antibiotics for this baby. Usually we give empirical ceftriaxone. So the treatment is ceftriaxone or antibiotics. So acute epiglottitis, bacterial condition, toxic child, thumbprint sign in lateral chest X-ray, very important that it is a lateral view, and the treatment is ceftriaxone. Now come to this X-ray. This is an AP or a PA view chest X-ray, and again look at the black pointed arrow. Can you find this lucent picture with a tapering top? This is known as the Church stipple sign seen in AP or PA view of chest X-ray, and this is suggestive of croup or acute laryngotracheobronchitis. So croup, another name of croup is acute laryngotracheobronchitis, and the most common cause of croup is definitely viral, and it is para-influenza. And as you can understand that viral cause, so there is going to be non-toxic child. So we are going to have a low-grade fever, non-toxic child with a stridor, and we can categorize on the basis of respiratory rate, retractions, mild, moderate and severe croup. Usually in case of severe croup, we go for adrenaline nebulization, which is known as the racemic epinephrine nebulization. So for treatment purpose, we can give racemic epinephrine nebulization and oral dexamethasone. Oral dexamethasone is usually given as treatment, and there is no role of antibiotics. And this X-ray, chest X-ray, PA or AP view is suggestive of the charge stipple sign. So croup is a vital cause. We need to give dexamethasone and adrenaline nebulization with a charge stipple sign in the chest x-ray. You can just outline the charge stipple over here. Okay. And it's acute laryngotracheobronchitis parainfluenza, whereas acute epiglottitis is a condition associated with a bacterial cause. Thumbprint sign in lateral chest x-ray, and the treatment is antibiotics, ceftriaxone, and since if the child presents with airway obstruction, you may need to intubate the child. Next, we are going to read the IMNCI or the WHO protocol for pneumonia. So this is nothing but the IMNCI or the WHO protocol for pneumonia. And this is again very important, because every year in INICET one question is there about the type of pneumonia and what is going to be the treatment plan in pneumonia. So this chart is very important. Now remember, any child who comes to you with less than 2 months, it is always very severe pneumonia. There is no term called pneumonia in less than 2 months. It is always very severe pneumonia. Okay, so in less than 2 months, since it's a very severe pneumonia, you need to admit the child and give parenteral antibiotics. So if you're working in a PHC, you need to refer the child. You need to give a first dose of antibiotic, oral antibiotic, refer the child, and because you need to start on parenteral antibiotics, need to admit. So what will be the symptomatology? There is going to be tachypnea and or chest indrawing or chest indrawing in a child less than 2 months, suggestive of very severe pneumonia, and we need to admit the child and start on parenteral antibiotics. 2 months to 5 years, there are two options. If there is only tachypnea or chest indrawing, we call it as a pneumonia, and we do as a OPD based management, we give amoxicillin. So it's a OPD based management, right? Whereas 2 months to 5 years, it's tachypnea or chest indrawing plus any danger sign. So we need to give severe or very severe pneumonia. So what is it called? Severe or very severe pneumonia. Here also you need to admit the child. You need to give parenteral antibiotics. If you are working in a PHC, then you need to give a first dose of oral antibiotic and then refer the child for consideration of parenteral antibiotics. So what are the danger signs in pneumonia? We need to remember. Number 1 is protein energy malnutrition. Number 2, convulsions. Number 3, vomiting. More than 3 per hour. Number 4, lethargic child. That is inability to feed or drink. And the last point is stridor at rest or stridor in a calm child. So protein energy malnutrition, convulsions, vomiting, more than 3 per hour purge rate, lethargy, stridor at rest or stridor in a calm child are the danger signs in pneumonia. So if you are asked in question, that is a child presented to you with tachypnea, with chest indrawing, with stridor, what is going to be the next line of management? So you understood that this is a tachypnea, chest indrawing with danger sign. So it is either a severe or a very severe pneumonia. You need to admit the child and you need to start on parenteral antibiotics for the child. Next, we are going to do a congenital malformation of the lung, that is known as the congenital pulmonary airway malformation. So it is also known as CPAM. First, we used to call this as congenital cystic adenomatoid malformation. So now we call it as congenital pulmonary airway malformation. So it is the most common form of fetal and lung malformation, right? So first of all, we are doing with a structural lesion which affects the lung. So it's the most common form of fetal and lung malformation. So what is the most common type? There are various types, type 1 being the most common. So we need to know what is the problem in the anatomy in congenital pulmonary airway malformation. Okay, so it is a unilateral involvement. There can be foregut malformations associated with it. So there can be involvement of foregut malformations. So when I use the word unilateral, it means it can be right lung involvement or left lung involvement. There is no predilection as such. Remember, middle lobe is least affected. Middle lobe is least affected. Very important. Middle lobe is least affected. Okay. So what will you find in clinical examination? There is going to be decreased vesicular breath sound. And there is going to be mediastinal shift. If you have done an antenatal USG, you are going to see the CPAM volume ratio. So CPAM volume ratio is found in, which is a predictor of CPAM in prenatal USG. What is the investigation of choice for CPAM? We need to do a CT scan of chest. So CT thorax is the investigation of choice, and we need to go for a segmental lobectomy. So segmental lobectomy is the treatment of choice. So congenital pulmonary airway malformation is the most common form of fetal and lung malformation. The most common type is type 1. We get a unilateral involvement in clinically as well as radiologically. It can be associated with other foregut malformations. Either it is involvement of the right lung or the left lung. And remember, the middle lobe is least affected. There is decreased vesicular breath sounds and mediastinal shift. In antenatal USG, we see the CPAM volume ratio, and the investigation of choice is CT chest, and the treatment being segmental lobectomy. Right? So that finishes our pediatric pulmonology, and in the next pediatric marathon series, we are going to do pediatric nephrology. Thank you.